And then what we're going to talk about today is we've had this chronic pain work group going probably about a year now almost, with a lot of hard work from a lot of people trying to sort out is there anything that we can use from the chronic pain literature with our chronic pain patients in the collaborative care kind of model and tradition. So, you know, we're not going to do big interventions around chronic pain, but we see so many people with it. We were trying to see if there's some things we can put together that might be helpful for everybody. So the way this is going to work is I'm going to just talk very briefly about how the body and the brain processes pain, which is interesting. And Donna couldn't be here, so I'm going to give very brief information on how some of the psychiatric meds can be helpful. And then we have a whole bunch of great people giving talks on self-management skills, ACT, CBT, just to give us some idea of what we might want to use. But while you're listening to this, I want you guys to think about whether there's parts of this that could be helpful for us to put together in some kind of a pamphlet book, some online thing or something, what you might feel helpful. And then T's going to end it all up by giving us some local resources so that we have some options for patients who need more. All right. So what is pain? We all look at this person and we know they're in pain, but we don't really usually think about what's the definition of pain. So this is the current definition. So it's an unpleasant sensory and emotional experience that is associated with actual or potential tissue damage or described in such terms. Not the greatest kind of definition. I think most of us were here when we saw the potential where, you know, the guy thought he had a nail in his foot and he was in excruciating pain and it really hadn't gone through his foot. So that's what they mean with that. But this is, I think, a much better definition, and it looks like it's probably going to be adopted soon. It's from the International Association for the Study of Pain. It says pain is a distressing experience associated with actual or potential tissue damage with sensory, emotional, cognitive, and social components. So it really pulls in the biopsychosocial model, which I think really helps. So this is interesting. There's two types of pain, right? There's the acute pain, which happens, you drop something on your foot, whatever. It's very protective. It usually lasts less than 3 months. There's actually an illness where people don't have good pain receptors, and they often die early because of injuries. So there really is a really protective functioning to it. The problem is when it becomes chronic pain, and that's the people that we see. So it lasts longer than 3 months. It persists after the apparent cause of the pain is resolved, and it's a distinct condition associated with basically changes in your central nervous system perception. So this is a fascinating study. So I want to read this so I get it right. So it was in the journal called Brain back in 2013. It's called Shape-Shifting Pain. So it was a study where they followed about 40 people with acute back pain, and they did 4 functional MRIs over 12 months, so once a quarter. And half of the study participants' pain resolved, so they stayed less than 3 months. They didn't go on to chronic pain, and the other half, nicely enough, went on to chronic pain for them. So the group who went on to have chronic pain demonstrated on their functional MRIs that the brain regions initially activated by the pain in everybody had started to shift somewhere 3 to 6 months to different brain areas over time. So the chronic pain was now activating some different areas. And it turns out that those are regions that are also involved with areas of the brain that involve processing emotion. So, and we'll talk a little bit more about that, but it was a really, really nicely done study. So this is from a Mayo Clinic article about how the brain processes pain. And I think if we understand this more, and if our patients understand this more, then some of the interventions everybody's going to talk about makes more sense. So these are parts of the brain. Oh, and the audience is coming. Hi guys, that's okay. So just to update you where we are. So this is from a Mayo Clinic article about our latest thinking, or their thinking, on how the body processes pain. So the first thing that happens, right? You fall, something gets strapped on your foot. So what happens is you have certain cells, they're called peripheral nociceptors, but they're basically the cells that take in this pain information. they're activated and they send their impulses to the dorsal horn of the spinal cord. And from there, it's then sent up to the posterior thalamus. So that first kind of brain slice that you're seeing. So that is where the brain processes the pain's location. You know, it's my foot, is it stabbing, is it burning? So those kinds of characteristics. But it's not done there. Then it goes up to the second tier, so the second order processing. So they go to these areas of the brain. It's the prefrontal cortex, the anterior cingulate cortex, the insula, the parietal. So it goes to these very specific areas. And this is where the pain stimuli are subjected to what they call attentional and cognitive changes. What does this mean? Is this important? Should I pay attention to this? So you're starting to add a layer of complexity to the pain. Still not done. This is where it gets really interesting, right? So this is the third tier, and so it goes to, again, little different areas, a little more in your frontal lobes there. And this is where what starts to happen is it's affected by the emotional context of the person, the actual type of pain that it is, their own individual psychological factors, sociological factors. So that's where it kind of gets really complicated. And to top it all off, those top two sections then can send some descending controls back down to the dorsal horn of the spinal cord and say, okay, stop, I don't need to know that anymore. Oh, yes, 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 I need to know more about that. That is probably where the SNRIs work. It's probably in that descending control area. That makes sense? So I think the main thing to take from it is that patients, you know, pain is complicated and individualized. Patients and providers need to understand pain is an output of the brain and not just something landing on your toe, and that it's going to be different for everybody. And so how do we deal with that? And that's where maybe using some of these other self-management, CBT, ACT, those kinds of things can help, which we'll get into. So this is the other thing. Is it common? 20% of outpatient visits are for chronic pain. We've looked at Mylan and Domino's Farms, and 30 to 40% of our collaborative care patients have chronic pain diagnosis. So you guys know that, right? You're seeing it. Over 100 million people in the United States, pain-related expenditures, I did not know this, direct costs and lost wages is greater than those for cancer, heart disease, and diabetes combined. So it's a huge drain on the resources. And with current therapeutic options, we're not doing very much in terms of helping people anyway. So this is my last slide, and then I'm going to briefly go through just something about some of the meds. But chronic pain and mental health disorders, there's a bidirectional nature and a lot of overlap of these diagnoses. So I think we all know that, okay, somebody has chronic pain and then they're going to get depressed. Well, people who start with depression have a 2 to 3 times increased risk of developing chronic pain after they're depressed. And in part, this is due to those shared CNS regions. We had talked about a really interesting study where they did functional fMRIs over 12 months in a group of people with acute pain, and the ones who went to have chronic pain, where the pain centers were activated, switched to a different area, somewhere around 6 months or so, and closer to where they're also evaluating emotion and sensations. So again, they're really kind of close to each other with chronic pain, not so much with acute pain. So this, and I just love reading this quote. So William Styron, I think many of you know him. He's great. If you ever want to understand what depression feels like, he's got a really short, great book called Darkness Visible. And so this is the way he's kind of described this phenomenon. He said, mysteriously, he's a writer, so mysteriously and in ways that are totally remote from natural experience, the gray drizzle of horror induced by depression takes on the quality of physical pain. So I think most of us have seen this. I've certainly seen it in my younger depressed patients who have nothing chronically wrong. They don't have arthritis. They don't have any of that stuff. And they tell me it hurts. And I say, okay, where does it hurt? And they can't tell you where it hurts. But there is this sense that it's a physical pain as well. So there are high percentages of all of these diagnoses in chronic pain patients, major depression, anxiety disorders, a lot of history of sexual physical violence, a lot of substance use disorders. A quarter to a half of chronic pain patients have suicidal thinking, a lot of sleep disturbances, and interestingly, half of all the opioids in the United States are given to patients who have a comorbid depression or anxiety diagnosis. So they're getting a lot of opioids. And we won't get into the fact that maybe sometimes opioids help them. So that's another discussion. So any questions on that? Okay. So this was done as part, and unfortunately she can't be here. Josh can't be here either, so Teague's filling in for him. And I'm going to briefly go through this. There's kind of 3 types of pain. Nociceptive, which is like tissue damage. It can be from trauma, it can be from inflammation, arthritic pain, inflammatory bowel disease, tumor-related tendinitis, those kinds of things. If prolonged, you can start getting hyperalgesia where like everything starts to feel painful. But what they're really recommending is a great article that Dr. Clow, the fibro guy, wrote. Wrote with a lot of other people, Rethinking Chronic Pain in Primary Care. It's a great article. This is where this is from. This is the group where you want to give them like Tylenol and Motrin and corticosteroids, and you want to treat the underlying illness. Then there's neuropathic pain, and you guys see that a lot, right, with your diabetic patients and the peripheral neuropathy. So that's damage to the peripheral nerves or the central nervous system. So you'll see post-herpetic neuralgia, chemotherapy-induced post-stroke pain, MS pain, so pain that involves the peripheral nerves of the central nervous system. This group, and then the next group, which is called different things, sensory hypersensitivity, central sensitization syndrome, but it's basically pain without identifiable nerve or tissue damage thought to result from persistent neuron dysregulation. And this is the fibro. You guys see this all the time, right? Fibro, IBS, tension headache, interstitial cystitis, chronic fatigue. These 2 groups do much better being treated with the antiepileptics, so gabapentin, Lyrica, the SNRIs, or the tricyclic antidepressants. And they really say, especially with the sensory hypersensitivity group, they should never be put on opioids because they are just not going to do well. And in fact, they're going to do worse with those. And the interesting thing is both the SNRIs and the tricyclics help even if the person is not depressed. And she was saying the number needed to treat is 2 to 3 for one patient to start to achieve some relief. So again, I think as the collaborative care psychiatrists, kind of doing some education and kind of thinking about that when we see some of the chronic pain people. Because there was a study done, it was 2008 to 2012, so hopefully it's better now, but 42 to 52% of patients with arthritis, painful diabetic neuropathy, and fibro were given opioids as their first-line treatment. Not what we should be doing, so. I'm not going to go through these. If any, the slides will be available. She went through and kind of listed the different ones and the doses and the side effects. So, we've kind of been through some of that before. Just all in there if people want to look. Tegretol is the one that's sometimes used for trigeminal neuralgia. The rest of them, it's really more Neurontin and Lyrica are the 2 that people are using. The SNRIs, right? You all guys all know this, right? It's Effexor, it's Pristiq, it's Cymbalta. And then the new one is levomilnalcipran. I don't know, has anybody used that? I have not, there's no generic, so okay. But that's another one that should kind of fit in there. And then the tricyclics, while there's no FDA indication, often just a little bit of that at night, especially if people are having a lot of trouble sleeping, often added to Cymbalta or Effexor can be really helpful. Ashley is now going to talk about self-management. So what we tried to do is, Rachel and other people who came in, we're trying to see, is there anything out of this literature that we can use in the collaborative care model? So if you're watching this and you think some of this should be put together in a big folder or something online, a shared drive or whatever, let us know because I'm going to try to put that together.
Okay. Hi, I'm Ashley. I work with the collaborative team at Michigan Medicine. So I just sent around some resources. 2 of them or 3 of them are books and resources that I gathered a lot of my information from and that I felt was really helpful. So I wanted to share that with you guys. The other 2 packets are packets of scales that I found through all the research that I did, just different scales, various scales that were used. So I wanted to show those to you. I did tell Sarah that I do have PDFs of all these scales and she'll send them out to you guys too so you can review them that way. I'm going to skip this slide because Pat just went through all of this. But what I found is that it was really important for the patients to know about pain, to understand their pain, and to understand, just have a basic understanding of pain and how it works. So that would be information that would be good for us to know if patients are aware of that or if somebody can go through that, and then for us just to have a general knowledge as well. And then also remembering that the pain that the patient feels is real. It's real to them. So trying to validate them and trying to just help them through that experience. So next, I found the pain cycle. So also helping patients to understand the cycle of pain and how that can lead to decreased activity and negative emotions regarding to their decreased activity, feeling like they can't do certain things. So reviewing the cycle with them and making sure that they're aware of this as well. All right, and then one of the other things that I found that would be helpful is to review the different treatment options with patients. So trying to figure out what patients have tried in the past, what may have been helpful, what wasn't helpful, what they may be interested in expanding and trying over time. So a lot of this included just all different medications used, injections, nerve blocks, surgeries, procedures, things that they can do in the home, heating and cooling treatments, massages, just outside the box, thinking of different things that may be helpful for them and reviewing them to see if they've done them, if they've been helpful, and then also exploring what they might be interested in helping in the future. I listed here in one of the books I used, they have listed by efficacy, the highest to lowest, and then also the risk of using these treatments, highest to lowest. And then if you notice that the behavioral treatment is listed highest on the efficacy and lowest on the risk, so that's something that we can directly help in. So with working with patients with pain, it's important to get a sense of what the patient's goal for treatment is. So talking to them and trying to figure out what it is that they want to see change, what they want to work on, and what they're most struggling with. Also trying to see where they're at in the stage of change. So are they actually wanting to and willing to make changes? Or are they simply wanting to continue to take their pain medication? Like where they're at and what we can do to help. All right, so I went through, like I said, I sent around some of the different scales that I found that were helpful through some of my research. These are all the different scales that are listed here. And I'll talk about these a little bit later in my research findings and see to let you know which ones were most often used. But then I also found phone applications that people could use on their phone. So the scales and the tools are things that we can help to do to monitor progress over time. But also phone apps can be very beneficial to patients helping to manage their own symptoms and their own progress. So these are things that they can do and then report back to us. I read an article on these phone apps that evaluated them based on their clinical content, the interface, the usability, and the overall app. What I found was that based on clinical content, the Pain Diary and Chronic Pain Tracker were the two top rated. Based on interface, Pain Care and Pain Diary were the best. Usability was Pain Diary and Or Manage My Pain. And then based on the overall app, there was the Pain Diary and Track and Share. All right, so self-management types. These are things that we as care managers can do to help patients. And these are things that a lot of us do already, like the relaxation techniques, the progressive relaxation, deep breathing, imagery, mindfulness, and even behavior activation. Those are all things that we're doing, and that we're all pretty well aware of what they are. I wanted to just touch on sleep. So a lot of people who have pain may also be struggling with their sleep. So trying to really hone in on that sleep hygiene and what may be impacting their sleep, trying to go through that with them, trying to see if there's any medical issues that are either being addressed or not being addressed, their environment, really trying to see what factors are impacting in their environment. So pretty good sleep techniques. And then also if you're talking to them and they feel like they're having a lot of pain at night or due to depression or anxiety, they're not able to sleep, really trying to talk to them about the skills that you're using with them. So the mindfulness skills, the relaxation skills, deep breathing, all those things that can be helpful in the moment when they're having difficulty with sleep. All right, and then also with behavioral activation, one of the things is to really trying to get them integrated into different activities. So using the different like activity charts to try and help track what they're doing throughout the day, that can be helpful in tracking trends throughout the day and scheduling planned activities. So trying to see if there's different parts of the day that are better or worse for them, or they're more productive in the morning versus at night, and just trying to use those types of resources. And so the activity scheduling can be very helpful. And then pacing. So this is something that I've used maybe once or twice, and it wasn't that helpful. I think the patient was really resistant to it. So this is something that I'm looking forward to integrating in my practice and the patients that I'm working with. But talking to them about the goal of pacing and their pain and just overall information on pacing when you're very first talking to them, letting them know that we're trying to implement the goal of pacing and for them to not push themselves too far so that they get discouraged. And then also helping to try to find an amount of time that they can complete tasks without experiencing debilitating pain would be parts of the goal to go through that. Ways of evaluating pacing would be based on some of the questionnaires that we use or different surveys that we use, and then also based on self-report. When trying to find a task, what I found out is to, like I said, trying to find a task that they can complete without being in debilitating pain. So having them identify a certain task that they want to do, try and set an activity time and then also a resting time, and then practice that for the next 3 to 4 days. See if it's tolerable. If it's not tolerable, then trying to adjust those times has been very helpful. So for example, maybe I don't know, putting away clothes, if that's a difficult task for them, maybe trying like folding for 10 minutes, resting for 15, putting part of them, like doing 10 and 15, 10 and 15, but making sure that that is consistent, that they're going back to the pacing, that they're not doing the activity, resting, and then not re-engaging in the activity. All right, and then also trying to have the patients record their activity time can be very helpful. So like the planned activities, also recording the activity time that they're having. So recording activities and the resting. So, and then also how they felt during the activity or felt during resting and how that may different. Also, we want to see if the patients are overextending themselves. So if they're going to the point to where they want to finish the task or they're doing too much activity and it's becoming problematic for them. So we want them to keep track of that and how often that's happening. Or on the opposite end, if they're able to notice that they're getting to that point of overactivity, trying to mark that down as well and trying to see what rest time that they had after that was helpful. Okay, so this is just an example of how you could implement pacing. Like I said, trying to identify an activity that they want to work on. One thing that I found is that you want to start with something that is not extremely strenuous for the patient. So trying out something that is pretty simple, maybe something that they want to work on over time, lengthening the time of the activity that they can do. So starting out with something that will be helpful but not too hard, and then just going through and trying to identify the activity times, rest times, and then making sure, like I said, going back to the activity, not stopping after the first round of pacing. And then just remembering that you always have to continue to assess the progress, assess what you're doing, and make changes if needed. Okay. So the research that I did on different places that have integrated self-management and pacing really differed across the board. Some of the studies had really great results, some of them not so much. I'm going to talk about just briefly talk about two different studies that I went over. One, and I think a lot of it that the progress may have had something to do with the different composition of the treatment teams, who was relaying the information, and the length of treatment time. So it really varied. There were some that were a couple weeks, there were some that were over a year. So the treatment process was very different throughout the different studies that I read. There was one study that was over a period of 2 years, and there was no significant outcome and differences in the study versus usual care, which I found interesting. But once I went through the study a little bit better and tried to get an understanding of who was implementing these interventions, I found out that the study there was a physical therapist that had implemented the services, and there wasn't enough time, or there wasn't sufficient time for the physical therapist to learn the techniques. There was only 2 days of training for this physical therapist, and he worked with these people for over a year, but he was the only person on the treatment team, and it didn't seem like he had a lot of training throughout it. Like I said, there was no difference in the outcomes, and it looked like that the patients were not as adherent to the program. So they weren't completing journals, they weren't completing the practice techniques, like they weren't doing things outside of the study. They weren't implementing things in their home. There was another study that I read that had 68 adults, and they worked on this for a period of 3 to 5 months. So it varied with different participants of the group. But this was an extensive 5-day training for the patients. So the patients were in training for 5 days straight. And then they also wore an activity monitor at home to monitor their activity in the home and the progress. And they kept journals and activity sheets and all of that. Their treatment team was a composition of a social worker, a doctor, a nurse, a physical therapist. There's a lot of people on the team that helped to support that person. And in that study, there was a 60% decrease in symptoms in the treatment group, so in overall symptoms. Okay, so these are just some general questions and ways of gathering information when you're working with a patient who has pain. This just gives you an idea of some additional questions that you can ask them for further information gathering. I know that through our assessments, we talk to patients and we get a lot of good information, but sometimes these questions can help trigger other questions throughout the assessment. And I believe I went through all of these already, but one of the main things that I read was to make sure you take breaks and that you're getting that sufficient time of the pacing with taking the activity and then also taking breaks and then going back through it and practicing often. So through my research, one of the things I was going to go over was also the scales that I found in the research that were used most often. So I found that the Roland-Morris Disability Questionnaire, the PHQ-9, the Brief Pain Inventory, and the Hopkins Symptom Checklist. Those were the 4 that were used the most throughout my research. And then the resources that I sent around, those are really useful resources that I found to be helpful.
Oh, okay. Thank you, Ashley. That was a lot of good information. Like I said, I'll send that out or post it somewhere. We'll figure out how to share everything. I think the theme of today is that there's a lot of really good information in all of these presentations, and we could spend a lot more time talking about everything. But again, we just want to provide a brief overview of some resources and ways to learn more if you're interested. So Ed and I will be talking about acceptance and commitment therapy. You'll also hear it referred to as ACT, if you are familiar with it. So we have about 5 minutes to go over this, given everything else. So we're just going to kind of talk about what it is and some basic concepts that we can use with our patients and where you might learn more. So I think Pat did a good job of kind of going over this concept, but the reality is that physical pathology doesn't relate so much to patients' experience of pain we're finding, right? So in almost every area of chronic pain, the relationship between how patients are functioning or their level of disability and the amount of their kind of their experience of pain, that's a weak relationship. So Pat explained that there's a lot of different processes that pain goes through in our brain that really impacts how patients experience it. So what does predict functioning? So from an ACT perspective, there's a few things that are highlighted. So the first thing is patients' willingness to experience pain. So are they willing to kind of consider what their overall goals and values are, kind of like Ashley just mentioned in the last presentation, and in a structured way and with some tools at hand, are they willing to kind of move forward toward those goals despite having pain on board? Also, again, are they willing to act in a valued direction? Values are often, we know, the things that really motivate us to make behavior change. It's not our doctors telling us what to do or all of the shoulds that exist in the literature. It's what's important to us. So patients who are able to kind of make that connection tend to do well. Understanding the difference between pain and suffering. So you may have heard this before, but it's a big tenet in ACT. So essentially it's that, you know, people can have pain, but they don't have to suffer in their lives. They can live a life with pain as a part of them, but it doesn't have to impact every area or stop them from doing the things that are important to them. And then psychological flexibility as well is a big tenet of ACT, and Ed's going to talk a little bit about that in the next slide, so I'll skip. But just a quick intro to ACT. So acceptance and commitment therapy, the evidence is growing. It's really been around since the 80s. So it was developed by Stephen Hayes in 1986. This is a picture of Stephen Hayes doing a TED Talk, actually. It's kind of an interesting one if you want to look it up. He's an odd guy, but yeah, it's very interesting. So the evidence is growing. The range of populations is growing. It has really strong support for chronic pain, actually. And it has modest support for other conditions such as depression, mixed anxiety, OCD, and even psychosis, which I thought was interesting. So a lot of studies have shown significant improvement in depression and experience of pain intensity. And in reviewing the literature, they're testing the use of ACT in a lot of different delivery methods, including a more traditional psychotherapist, self-help methods such as workbooks, face-to-face, or via electronic methods, so sort of like a standardized computer program that patients work through.
So we're going to take just a couple minutes to go over ACT. ACT is a bit of an eclectic therapy, so it's kind of hard to describe in 2 minutes, but I'm going to try. So and if there's any ACT therapists in the room, I apologize for what I'm going to do. At the middle of ACT is this idea of psychological flexibility. The best way that I know to explain that is the ability to cope with internal and external stressors while continuing to move forward. Oh, we're using mic, sorry.
Okay.
While continuing to move forward in a values-oriented direction. So ACT puts values very front and center, as Sarah said. So you often see the different, the 6 core principles of ACT laid out in a hexagon like this, with the idea that different patients might need different work in these areas. And the 6 core areas, first and foremost, are core values. So there's a lot of conversation with the patient about what is most important to you, what do you stand for, being careful to separate values from goals. Those are 2 different things. One of the metaphors I like is they think about values as a direction on a compass, and then the goals are to help you move in that direction. Another important, or one of the core principles is committed action. So I think about that like the goals that you make. So you set your compass by your values, and then the committed actions, how do you get moving in that direction? So you think it feels a lot like behavioral activation. How do you get people moving? There's a lot of mindfulness component, which is captured here in the present moment. So a lot of it's focusing on what's going on in that moment, what are the thoughts and feelings you're experiencing. The idea of self as context is kind of hard to wrap your head around. It's hard for me, at least, to wrap my head around. It's kind of similar to the psychodynamic principle of the ego, this idea of focusing on yourself as the observer, as the person noticing these thoughts and feelings that you're experiencing. So a lot of the exercises under the self as context umbrella are good for patients who struggle with unsteady identity. For example, somebody going through a role transition, or maybe somebody with a personality disorder. The fifth core principle is this idea of diffusion. So being able to separate yourself from these negative thoughts and feelings that we experience, and recognizing that your thoughts and yourself are two separate things. There's a lot of exercises to help you separate those, so you can look at those thoughts and feelings more objectively.
Can I give an example of some of the exercises?
Sure.
So like they're kind of funny actually. So like one might be to have a patient verbalize a thought, which is I'm never going to feel better, for example. And you'll have them play with that thought in a lot of different ways. So you might have them visualize the thought in different fonts on a computer screen, making it really big, really small, all caps, all lowercase. You might have them sing the song out loud to different tunes. So the Happy Birthday tune is a very classic one in ACT. And it's all these different ways just to learn, again, to detach yourself from it. And it can, bring humor too, and kind of just help them feel less attached generally.
Mm-hmm. And then finally, the idea of acceptance, which obviously is the A in ACT. So this is where it gets distinguished from, say, CBT. So in CBT, the cognitive restructuring, like we're going to try to change this thought. In ACT, it's not we're going to change the thought, it's we're going to learn to live with this thought. And then how do you live out your life in a values-oriented way while also accepting that sometimes you have these thoughts or feelings. So those are the 6 core principles. And then each patient, depending on what kind of work you're doing, you'll spend time using different exercises in different, through these different umbrellas. So, and you can see, for example, some patients, like I mentioned, may need work in the self as context if they have some identity issues. Other patients, you can see elements of exposure, for example, in this idea of diffusion. Let's play with these thoughts and put them on the table and really spend some time with them, getting more comfortable with them. It has it feels very similar to exposure type exercises. And you'll actually see, as you see ACT therapists, they call it hexadancing, as they jump around the different parts of the hex, doing different exercises. And you can actually see that if you look at someone doing ACT down YouTube, you can actually identify which one of the exercises. So there's ACT in 2 minutes.
Yeah, so ACT is not linear, right? You can jump in wherever you need to or wherever the patient wants to or is willing to. So that really fits in well with a lot of the work that we're doing as clinicians and care managers. It fits in nicely kind of with MI, right? Meet the patient where they're at. So when we think about chronic pain, I thought I'd give a few different examples for how it might fit in with some of these core principles of ACT. So for example, Ed talked about contacting the present moment. That's an ACT term for mindfulness, essentially, which we're using with our patients. So we know that once patients are kind of taking committed action, so committed action could be a lot of things. It could be activity pacing, for example. Difficult thoughts and feelings are going to arise, most likely. So they might have those feelings like, this isn't going to work, this feels really bad, what's the point? So helping them to learn how to contact the present moment can kind of bring them back, get them out of their head, and hopefully allow them to continue with that committed action. We talked a bit about cognitive diffusion, but again, learning to diffuse from sticky thoughts. So those are going to come up again. So using some of the exercises I mentioned can be helpful. Another one that I find helpful and have used with patients before is, to give an example. So you have a patient identify a thought. So what's a thought we might hear from a chronic pain patient? Throw one out there. I can't stand up very long. Okay. So you're going to have the patient say that thought to themselves, I can't stand up very long. And you're going to have them notice how they feel afterward, what kind of emotions that brings up in them. And then you're going to have them say it in a slightly different way. you're going to have them say, my mind is telling me that I can't stand up very long. And you're going to have them sit, maybe breathe, and kind of notice how they feel after that time. And then you're going to take it just a little bit further, and you're going to have them say, I notice that my mind is telling me that I can't stand up very long. And you're going to, again, have them pay attention to how they feel. So the point of that exercise is obviously to just keep distancing themselves a little bit further. And that's a really easy one that we can use in a brief intervention too. And then value-based action. So is the patient willing, in spite of pain, to live life according to their values? We already went over this. So committed action is kind of interesting. So it's a key goal of ACT because ACT has very strong roots in behaviorism, and committed action is sort of where the rubber meets the road. So you're laying the foundation again with these types of things, and then committed action can really be anything that makes sense for the patient. So it can include any evidence-based intervention, whether that be full-blown CBT, whether it be behavioral activation with some of our collaborative care patients, whether it's activity pacing with chronic pain patients. So we can kind of teach them these skills, give them the education in the other parts of ACT, and then move forward with committed action. So again, that was ACT in I don't know how many minutes, very quick, but we wanted to give some ongoing resources that you guys can check out. The one on top, ACT in Context, is actually a podcast that is really interesting, and I found it really helpful. They have a lot of really great guests on there. Stephen Hayes is actually on a couple of episodes, and they go through different topics. So like they'll go through the contextualized self, contact in the present moment.
There's like an hour-long episode on each one of those 6 core principles. Mm-hmm. And then they also do they do 2 intros. They do one on after adolescence. Can't remember what else, trauma. They do one on trauma. And they actually just rebooted the podcast as well. It came out in, I think, 2015, and they just restarted it like a couple of months ago. It's a great resource.
Yeah. The second book on here, Get Out of Your Mind and Into Your Life, is actually a workbook that could be helpful, I would think, to recommend to your patients if they're into that kind of thing. And then the others are just good text. The last one is by Patricia Robinson and is specific to primary care and is tailored actually a lot towards PCPs, but we can use it as care managers as well. And it has lots of worksheets and things we can do with our patients in brief settings. Any questions, or should we move on to our next topic? Great, right. We'll move on for time's sake. So that's Josh, AKA Teague.
All right. So as you can see, Josh has some really great things to say about CBT in collaborative care with chronic pain patients. Josh is sick, unfortunately, so I am going to try to do his work justice. So just quickly, is everyone in here familiar with the basic concepts of CBT? Okay, great. So CBT for chronic pain, and what I want to say first is as I'm listening to all of these different interventions, there are so many ways that we can work with our patients to get at what we need to get at based on who they are, how they respond. I'm thinking of some patients who would respond really well to ACT, some patients who I could just jump right in and do activity pacing. And then CBT is another way that we can get at this chronic pain issue with our patients. So CBT for chronic pain helps patients to kind of work on some of those negative thoughts that come up with chronic pain of, I'm hopeless, I'm never going to feel better, because once you have one doctor or one person or you yourself think, there's nothing we can do here, like there's nothing physically wrong with you, which is what a lot of chronic pain patients hear, it's so easy to fall into that feeling of hopelessness. So CBT is really helpful to work on some of those automatic negative thoughts. I'm going to fly through this because we've talked about the brain a lot today, but I think it's important for our patients to know, maybe in a really simplified way, that the way we act and the way we treat ourselves emotionally really can have an impact on how we experience pain. And so we know that things that can increase pain are too much or too little activity, negative mood, negative thoughts, and we know that things that can kind of narrow that pain gate, the way that we're experiencing pain, our activity pacing, positive mood, and positive thoughts. So this is a really great concept that we can talk with our patients about, the connection between stress and judging and pain. So first, stress and pain kind of go back and forth. Pain causes stress, right? Like if I drop a hammer on my toe, I'm going to be stressed. No one else. Stress can cause pain. And then management of stress can also help to manage pain. And so we see stress playing out in these 4 different ways. So you have the biological way. When you're stressed, you have that fight or flight response. You have your emotional response. So things like feeling sad, feeling angry, feeling depressed. Stress in a cognitive way can look like I'm never going to get better. I'm always going to feel miserable. My life is over. And then behaviorally, stress can look like I'm not getting out of bed. I'm avoiding the things that I love. So helping your patients to understand that however stress is manifesting, that can have an impact on pain, and vice versa. And then the stress judging connection too, it was something that I found really interesting. So I don't know, I've never heard of this before. But the stress judging connection says that there are 3 ways that we can judge our stress, and that has an impact on how the stress plays out. So we'll use the example of I'm looking for a new job. So judging your stress from a challenge-based perspective or a challenge mindset says I can work really hard and nail my interviews and have a really great resume and have a pretty good shot at getting a job. So taking on a stressor or a situation as a challenge and something that you can use your coping skills to take on and perhaps succeed at. We can also judge stress as a threat. So maybe not automatically going to be bad, but there's some sense that my safety is compromised or things aren't going to go well. So in the job situation, it might be like, oh, I'm up against so many amazing applicants. I don't know how this is all going to go. And then the loss mindset when it comes to judging our stress is automatically things are not going to go well is the mindset that you have. So like, there's no way I'm ever going to get a new job. That's that loss mindset. And so what we'd like to move patients towards is a challenge mindset and away from so much of that threat and loss mindset. And then as they're doing all of this work with all of these interconnected things, distress tolerance strategies are huge. So you do some of these things, you do some work, and then rest, digest what you learned, and you're kind of coming in fresh the next time you try it. Does anyone else think that's really cool? Great. And automatic thoughts, in CBT, we know the impacts that automatic thoughts can have. So I won't spend too much time on those, but especially when it comes to CBT, we're hoping to help patients move away from thoughts that are completely not true. So some thoughts that patients have about pain are true and logical, and there's evidence for them. Like if I drop a hammer on my foot, that hurts, like that's true. We might have some thoughts that are maybe we believe and maybe there's not some truth to them, but then there's also flat out thoughts that have no evidence behind them and that are really, really limiting. So those are the thoughts that we hope to help patients shift. And Josh used the term stream of consciousness and stream of thoughts when it comes to this. So we want to quiet some of those thoughts that can be really loud and really overpowering about, I'm never going to get better. This is always going to be terrible. I'm always going to have a really hard time, and help patients to create some new alternative thoughts that might serve them a bit better. So things like, I am not my pain. Or when I'm in pain, there is lots I can still do instead of sitting in my chair. So helping to reframe some of those thoughts. And last but not least, when it comes to CBT, we can also talk to patients about their deeper beliefs or their core beliefs, especially if someone has been dealing with chronic pain for a long time. It can really become part of their identity. So like at my core, I am in pain and I'm never going to live a good life. So helping patients to examine those core beliefs and really assess, is that true? And also, is that helpful to have that belief? And maybe, if you could picture yourself as someone with a different core belief, what would that be? And why don't we try that? So are these beliefs helping me or hurting me? Are they working for me or working against me? As well as a lot of the shoulds. So in chronic pain, there's a lot of like, I should be up, I should be out and about, but also I should be feeling better by now. I should have never lifted that box that tweaked my back that started this whole thing. You can really get stuck in the shoulds. So CBT is great for these patients who are having these automatic thoughts, these should beliefs, and have these not very helpful core beliefs. So while we're not going to go through and do a full course of CBT, obviously, for our collaborative care patients, we can work with them to understand a few of these concepts. Great. Josh has some references.
Why is Josh so bad with hammers?
I don't know. That's not the reason he fell today, though. Not a hammer-related incident. This thing. Yep.
All right, I'm Pooja. Like I said, I think I've met some of you, but not all of you. I'm an internist here at Michigan and at the VA. And I just ran a pilot study that was evaluating a pharmacist, a clinical pharmacist within 2 of the primary care clinics here. And so I'm going to talk about that. So a little bit of a shift from behavioral therapies back to medication management. So at Michigan, especially, we have clinical pharmacists that are embedded within our primary care teams. And they usually help with medication management for chronic diseases. And this is what they can be reimbursed for as well. Based on insurance status. So diabetes management, hypertension management, and hyperlipidemia management. And in these models, the clinical pharmacist basically sees the patient along with in a separate appointment from the PCP, and will often have frequent appointments and phone calls to basically discuss things like, tweaking their insulin, going up or down, and doing some kind of diet counseling, but not too much of it, but really kind of focused on medication management and doing it kind of in short bursts. And that way they can space out the primary care appointments to longer intervals and hopefully obtain kind of better success with medication management. So this pilot basically came from the idea that there was this potential to expand the scope of practice to help use clinical pharmacists to manage patients with chronic pain and opioid use disorders. And the VA has already been doing this to some extent. There are some pain pharmacists that are embedded within our pain team at the Arbor VA that works with a pain anesthesiologist and do some of the medication management components. But these pain pharmacists look different across all of these VAs. So there was this thought about, could we do this also in our primary care clinics outside of the VA? So conducted a pilot feasibility and acceptability trial to evaluate basically putting a pain pharmacist in 2 Michigan medicine clinics. So this happened at East Ann Arbor and Domino Farms, and it went from January to October of this year. And this was funded by the Blue Cross Blue Shield Foundation of Michigan. And the objective of this pilot was basically to say, do clinics and physicians find this acceptable and or helpful to have this pharmacist to manage pain? Are patients willing to engage with a pharmacist, and do they find these consultations beneficial? And then we also kind of hope to gather some preliminary efficacy measures to see, are opioid doses changing at all? Are patients kind of changing on their scale of buprenorphine or naloxone management? Are we doing a better job at kind of meeting quality metrics, such as checking the prescription drug monitoring program or urine drug screens? One of the other main focuses was that we were going to focus initially on high-risk patients that were on opioid therapy for chronic pain, and or patients that had kind of complex persistent dependency or this kind of borderline overlap between pain and opioid use disorders, to see if maybe our pharmacists could even encourage buprenorphine uptake not only prescribing it from an addiction standpoint, but really thinking about using buprenorphine for pain to more safely manage their pain. So the intervention, first, we basically started with a pharmacist who already had some pain and opioid use disorder kind of experience. He worked in the pain clinics a few times. He was a palliative care pharmacist on the inpatient side. So this was an experienced pharmacist. This was not taking one of the ambulatory pharmacists that's just managing diabetes at this point. And the intervention basically would consist of this one in-person consultation with the pharmacist, where the pharmacist would meet with the patient, discuss their pain, figure out which therapies they've tried, which medications they've tried, which non-pharmacologic therapies they've tried, and then come up with some suggestions to feed back to the patient and the pharmacist, but then also kind of think about, does the patient have an appropriate referral to behavioral health or pain psychology, et cetera, just sort of become the quarterback for managing these patients. So in the pilot, there was this option that the pharmacist would do follow-up telephone interviews or follow-up in person over the 4 months. So we ran the pilot, and during the pilot, the pharmacist saw 47 patients out of what we felt like were 182 eligible patients. So these were patients with chronic pain on chronic long-term opioid therapy. So this couldn't just be somebody who had pain and was on an SNRI, for example. 55% of our sample was female, and the baseline opioid morphine dose was around 36 milligrams. So the pharmacist, this just kind of gives you some example of what the pharmacist did during this initial consultation. We did not put strict guidelines on what he could address during the pilot. And so as you can see, he often addressed kind of thinking about changing up their opioid medication. He suggested switching to buprenorphine quite a few times, which kind of indicates that patient population likely, a lot of them met criteria for complex persistent dependency and or underlying opioid use disorder. But he was really thinking about, in this situation, switching to buprenorphine for pain management and not necessarily addiction management. He also, thought about switching to other opioid formulations, opioid tapers, other non-pharmacologic management, and referrals to specialists. As you can see, there was, he's a pharmacist, so there wasn't quite as much, suggesting non-pharmacologic measures here. But he did kind of suggest, gabapentins, the SNRIs, TCAs, that type of thing as well. So quick feedback that we got so far. So we basically surveyed the patients at baseline. We also did some post surveys. And then we also did some qualitative interviews with the providers and patients to see how can we scale this up or what changes do we need to make before we do this. So the patient feedback said, talking was good to help, get through understanding of the medication. Terrific, very professional, in-depth discussions that were helpful to answer questions. So in general, patients, came away from the sense of like having this devoted 30 minutes to discuss their pain and all the therapies they tried was beneficial to them. But this is the negative stuff. So I found that the pharmacist's recommendations were the most helpful to me, informing me of medications that could be beneficial alternatives to my previous medications. More coordination with my primary care and neurologists. Neither of them even knew that this program existed when I spoke to them. So perhaps, really improving on the coordination of care. The other negative things that we heard was it helped me get my pain under control, and it's getting everything around and stuff. These medications, I guess, my doctor can't prescribe because he's not that kind of doctor. Maybe that could be true today. And we believe that this was in referral to the buprenorphine. Our pharmacist was suggesting buprenorphine prescriptions in the setting of pain, which doesn't require special waivers. So technically all of our PCPs could have prescribed the buprenorphine for pain. But many of the PCPs who were not waivered, we only had one that was in this entire sample, felt uncomfortable using the medication irrespective, whether it was for pain, whether it was for opioid use disorder. And, they really they were not okay with that recommendation that was being given by the pharmacist. Provider feedback, so here was some of the PCP feedback. I think one advantage is the pharmacist is the expert in drugs and medication side effects, and the whole being able to explain the pain pattern and help patients respond to their long-term narcotics. And I'm not sure that much education is given out at the other places. What they wanted more of is they said they wanted more specific dosing recommendations, so they didn't have to look things up. And they also said that they wanted more like concrete protocols basically on if I'm going to use this medication that I've never heard of, whether that's an SNRI, whether that's a buprenorphine, whatever that is, you've got to like put it down for me step by step, explain everything to me, and basically hold my hand through the whole thing. So the pharmacist's feedback said, I think once the word got out that we were seeing patients, then more patients seemed to come through. I think that now it's a matter of refining. And I think the next step would be either expanding it to other available clinics or building in a structure which for certain patients, part of their care would be required to see me before going to their primary for a refill or for their next visit. I think that we have seen a good number of patients, but I think that there are many patients that decline the study that also need help, and it's a tough population to get to. So we ran the study as a full research study and not as a quality improvement study, although that's debatable. And so all these patients had to go through informed consent. And there was some thought about, if this was just embedded into the care model that, for every patient that, we're considering or thinking about, long-term opioid therapy, or we're trying to taper you off of it, our pharmacist is going to help you manage that. So that was kind of where the pharmacist was getting at. He felt like we were missing a large proportion of the patients that could have really benefited from this consultation. So when we looked at pre-post scales, there was actually a trend towards improvement in the COM, which is an opioid misuse scale. There was an improvement in mental functioning on the SF-12. There wasn't any difference on the physical functioning scale, which I would find hard to believe in a 4-month period. More people, we did ask kind of baseline knowledge around buprenorphine and naloxone. So more people reported knowing about buprenorphine moving in because the pharmacist was recommending it as much as he was, and believing that it could also be used for pain and not just detox and rehab. Those were the other types of options that they had for that question. Pain scores, physical functioning scores stayed relatively the same, and the average OME did shift lower, but it wasn't significant. A lot of our results, as I said, was 47 patients. We had one patient that had a surgical procedure that went from like 5 OMEs to all the way up to 80 over the course of this 4 months. So our data got skewed a lot because of a couple of patients. So, this just got done, and I think that we obviously have room to modify the intervention, thinking about these protocols, thinking about if we have these protocols, could we train the existing pharmacists that are already in a lot of these clinics that currently manage diabetes to do this? Is there a way for our pharmacists to do some brief, behavioral interventions? Because there was some question about, could we pair the pain pharmacist with a behavioral therapist? Well, that would be ideal, but if we can't find a therapist, how do we kind of accommodate that situation? The other option that things that we've been thinking through are, is the initial consultation. Sometimes these consultations can be done by phone, and often by, a detailed medical record review. Would that expand the scope? So if we have a pharmacist sitting at Domino Farms, is that pharmacist potentially available to the other 9 clinics? We will be kind of thinking about refining the intervention and doing this in a larger efficacy trial. As I said, pain pharmacists are kind of widely used in the VA. None of them have been really tested to see if it really does improve medication management or, shifts so that people are using non-opioid therapy more or less. And so we are kind of in this phase where we're thinking about how do we modify the intervention and then scale it up. And Michigan in general has been kind of a leader when it comes to clinical pharmacists, largely because of Amy Cho's work, but she's done a good job of kind of getting reimbursement models to really reimburse for their time as well. And so there is this room to really kind of think about embedding pharmacists within these collaborative care models and seeing how it can be used in the future. And that's it.
And then just really quickly, because I know we're over time, these are some chronic pain resources in Southeast Michigan that we have found. But when we send out our kind of post-meeting email, we'd love to hear if you have others that you'd recommend, because there's not a lot out there. So the more the merrier. And then once we get all of those, we'll send those out and we send the rest of the information in kind of a nice digestible format.